Welcome back. We did a little session before. I thought it was a great live case, and we talked about intermediate polyps. This is about the big stuff. Just to start by saying, have a think about what you were trained to do. Most people get trained on insertion. When you reach the cecum, often you're then left in the room on your own. Lesion recognition tends to follow on, and then eventually polypectomy. And that requires its own technical skills. And I think one of the issues is that we don't really formally train people to do polypectomy. So you can be competent in colonoscopy, but not in polypectomy. If you're going to tackle a larger polypectomies, you're going to require some additional training. So I think the theory is important, but you need practical training, and it's beyond the remit of this lecture to give the practical training in large polypectomy. The organisation is critical, and you need to be explicit about what is expected from both the service and what you're going to provide the patients and the risks and benefits that they're going to be subjected to because of what you're going to do. So we know that not everyone will be able to do this, and not everyone can move every type of polyp. But I think you should know what you can do at what level, and then refer if necessary. And if you are effective in what you do, and by effective I mean you've completely and safely removed the polyp, you will save lives. So I would urge you to think about this. You need the technical skills to get to the lesion. You need to recognize it's a lesion. You need to make some judgments about what you're going to do with the lesion, and then you decide whether it's for you or not. And I'm going to introduce this concept of a graded competence based on level of size or complexity. So it's critical you have teamwork and a formalized process. And as I say, you need to have this monitored. And I think critically, particularly when you're starting off, you need adequate time on a list to start this sort of practice. And I think importantly, you need surgical backup because you will have problems.
The last thing I'd want to ask you about this is how would you start it?
Yeah, that's a good question. The first thing to recognise is that in the cecum, when the lesion is in front of you, the risk of transmural injection, as John mentioned in his earlier talk, is much, much greater. It's sort of approaching the inevitable. So you have to bear in mind that as you make the injection, you can easily go full thickness, and then afterwards the patient will get pain, but they'll be fine, but they'll have this pain and it'll delay their discharge. So very carefully try and find the submucosal plane. When you're tangential, it's much easier to find the submucosal plane. When you're perpendicular, as you're going to be, no matter how you change the angles, it'll still be somewhat perpendicular. You just go straight through. So you definitely got to start the injection on the outside. You always, with EMR, want to start more or less 90% of the time in the most difficult spot. Here, you want the elevation to take you away from the appendiceal orifice. If you make the injection on the other side, it will drive you back towards the appendiceal orifice. So you want to inject, elevate, and lift this out into the lumen away from the appendiceal orifice.
All right, let's try that. So I've already got the nurse assistant to purge the catheter, and so I'll ask her to start injecting. We're not under the lesion yet, and then I'm going to stab it. And then I'm going to lift up like this. Yeah. Come on, out, out, out.
The problem we have, and I'm going to try to move on a little bit quickly, is that we still got people operating on things which are benign. And it's my belief that I think the majority of things that are benign, if not all the things that are benign, can normally come out endoscopically. It's not necessarily the right thing to do for the patient because there are other factors involved, but I think they are technically removable. So if you're referring people to surgery for benign pathology, there's probably another option which you haven't explored, and I would encourage you to develop networks to enable this to occur in a safe manner. And what we find is when we get referrals, people have poor decision-making and lesion assessment, and sometimes I get referred to something which is clearly a cancer which I can't do anything about. Patient makes a big trip up and has to go back. So on that, please take lots of photographs as well as describing it in the lesion. And you should I would encourage you to take pictures of the whole lesion in as many views as you can. There's no such thing as not too many photographs. So you should take as many as you can. You need to have really good tip control, and just because you can reach the cecum doesn't mean to say you can take polyps off. They are different skills. They are complementary, but they are different skills. And I think you need a full set of kit. And, you know, I'll often go through three snares. If I take a lot of polyps off, you can get fatigue of snares. And I think you have to understand when that happens. And you have to be familiar with diathermy principles to minimize the risk to the patient. And then finally, you have to have adequate time. And initially, you're going to take a long time, and someone has to be really patient with you. And as you get better, you get more efficient with your time. So things like this, they can be resected. They're not easy. And actually, the more difficult it is, I think the increased risk of recurrence. Okay? But the early cecal valve is fine. You have to then consent the patient with the risk of recurrence and what that involves, versus the risk in this case of maybe having a limited right-sided resection or right hemicolectomy. What you don't want to do is have a go at it and then have recurrence and have 3 or 4 goes at it and then send it for surgery. That's an even worse outcome. Dentate line can also be tricky, but I think with the advent of ESD and using lignocaine and different tips and tricks, I think these are less problematic than they were in the past. And then IBD is a different area, which I'm not going to go into. But the trouble with IBD, and in fact, any inflammatory process, is you obliterate the planes. And it makes it very difficult to do simple snare resection, and they run the risk of having recurrence. And ESD is equally difficult because you're still dividing planes with risk of perforation. It is possible, though. And then there's some things you should definitely not attempt. So on the left, you've got a lesion. And I say that, and then I saw Toyonaga take one of these out. So this is growing out of the appendix, so I wouldn't advise you to do this. And the one on the right-hand side is a frank malignancy. So you need to be aware of what not to tackle as well as the ones that you do need to tackle. And you need to have some way of deciding why you're not going to do this. Non-lifting sign, I just mention it because that may be due to your lifting technique. So you need to have other parameters other than a non-lifting sign. And these are just some examples of cancer.
So there are 2 others that, yeah, there's the HIEQs study, which is excellent study. And 800 patients, you know, randomized clip, no clip, and bleeding risk reduced from 9% to 3% overall, particularly in the right colon. The benefit's just in the right colon. And then there's the Eduardo Albanese study from northern Spain, from Pamplona, which showed similar results in about 210 patients. And then there's our study, which is about 250, randomized clip, no clip. And the results are the same from all 3 studies.
Yeah. Have you got any experience of that?
No.
So
Show me on this proximal side, it looks much better. And of course, you don't have to use the tip of the snare. You can use the side of the snare. So here, I think you're more using the side of the snare like a blade.
Let's try and make it better.
Yeah.
David, turn it up to about 5.8. You'll have a setting of 4 at the moment or something?
It's 5.1 at the moment, John, so okay, we go a bit higher.
Yeah. So they're going 10 increments of 10, obviously. It's quite easily controlled, but I have had a similar problem. We just turned it up a little bit.
Yeah, so that accounts for the difference in the efficacy in the randomized trial versus the multi-center international trial, where we really knew how safe it was. I mean, of course, you don't want to hit the defect, but you know, if you're quite aggressive, then recurrence just doesn't occur. It's in my own practice, I never see it. We used to. I mean, David and I prepared a paper on the endoscopic treatment of recurrence, but basically, it's going to be a moot point.
Yeah, we better get it in soon, Michael. Otherwise, we'll be unable to do it.
I mean, once people learn how to do this, if they're employing high quality EMR technique and they recognise a few of the other things, and you can extend it out. Like I would just extend your snare tip a little bit.
More than that?
Yeah.